demonstrate the PA oblique projection, specifically the right anterior oblique position of the patient and the lateral projection, specifically the right lateral position of the patient. First, we're going to demonstrate the right anterior oblique position of the patient. So, in patient positioning, position the patient is either prone or upright for RAO or right PA oblique. Then, in part positioning, center the sternum to the grid, rotate the patient's body 15 to 20 degrees to prevent superimposition of the vertebral and sternal images. Then make sure that you center the IR midway between the jugular notch and saphenous process at the level of the thoracic 7. The next one is always remember that you need to shield the gonads. Then in respiration, shallow breathing or suspended expiration should be instructed to your patient. The central ray must be perpendicular to the thoracic 7 of the central rays and enters elevated side of the posterior thorax approximately 1 inch or 2.5 centimeter lateral to the mid-sagittal plane. Then the collimation must be collimate 10 by 12 inches or 24 by 30 centimeter, then place the side marker in the collimated exposure field. So, we need to manipulate this one. Then collimate. Make sure that the patient's sternum is chin up. And make sure that the central ray must be perpendicular to the level of the thoracic 7, which is, you can locate it at the inferior angle of the patient's scapula. I think that's the point. Then in oblique or RAO position of the sternum, the evaluation criteria must be the anatomy demonstrated, which is the entire sternum superimposed on hard shadow. Then in position, correct patient rotation. Sternum must be visualized alongside the vertebral column and should be no superimposition of the vertebral and the sternal images. So in exposure, 3 to 4 second exposure using breathing techniques, long markings appear blurred, and optimal contrast and density to the visualized entire sternum. Then bony margins should be sharp. The next position is the right lateral position of the sternum. The patient must be, in patient positioning, the patient must be positioned, it's either upright or supine. Then, position the patient seated, it's either seated or standing lateral or recumbent. Then, in part positioning, the patient must be place the top of the IR 1 1/2 inches or 3 to 0.8 centimeter above the jugular notch. So this is the jugular notch. Have patient rotate shoulders and arms posteriorly for upright positioning. So posteriorly, put your hands at the back. Then, center the sternum to the grid and adjust to the true lateral position. Then always remember to shield the gonads of your patient because it is very sensitive edge. So in respiration, suspended the deep inspiration before or instruct the patient to suspend his breathing before exposing him. Then the central ray must be perpendicular to the center of the IR. entering the lateral border of the mid-sternum, and use SID of 72 inches or 183 centimeter. So the cassette that we're going to use here is 10 by 12 inches or 24 by 30 centimeter. Then collimate it at 10 by 12 inches. Then place side of the marker at the collimated exposure field. So, review, we need the central ray must be perpendicular to the center of the IR, entering the lateral border of the mid-sternum of the patient. So, this is the mid-sternum. Collimate it. And that's the patient positioning. So in evaluation criteria for lateral sternum, the anatomy of interest should be can be seen on the radiograph. So the intersternum must be clearly visible. Then in position, there should be no rotation of the sternum, and the sternum must be visualized with no superimposition of the ribs, shoulders and arms drawn back. So there should be no superimposition with that. In exposure, no motion, sharp bony margins, optimal contrast and density to visualize the intersternum should be demonstrated. That's